Good morning, and thank you everybody for being with us this morning. My name is Juan Velez. I am a psychiatry mental health nurse practitioner trained at a doctoral level, and I'm also the director of the licensed professional program here at Sierra Tucson. It's my pleasure today to talk about survivor's guilt and resiliency. Again, I'm going to turn off my camera throughout the presentation, and I will turn it on at the end for some questions. So without further ado, welcome and enjoy it. So let's start with survivor's guilt and resiliency. Survivor's guilt is an old term that it was coined in the mid-60s after the Holocaust survivals. We start noticing that many patients start presenting with the same symptoms, that constant anxiety, that physical activation, until the DSM-4 survivor's guilt was removed as an independent diagnosis and became a symptom of PTSD. So today in the presentation, we will be talking about survivor's guilt in the context of being one of the symptoms of PTSD. So survivor's guilt, as a definition, this is kind of the one that I like the most, and is when a person has feelings of guilt because they survive a life-threatening situation when others did not. So usually, guys, we are concentrated in the victim of the event, but many times we forget the people that witness it, and that's actually where we need to concentrate a little bit more. Survivor's guilt also is a common reaction to traumatic events. So it's expected that if you've been present in a traumatic event, you're going to have symptoms in some point of trauma. So as I mentioned before, it is not a diagnosis itself. Survivor's guilt is a symptom of post-traumatic stress disorder. We know that people that is more prone to present symptoms of survivor's guilt and PTSD are war veterans, first responders, people that deal with death all the time. Of course, Holocaust survivors, 911 survivors, also cancer survivors and transplant recipients. Many people in crash cars, natural disasters are also susceptible to present survivor's guilt. We know that 89% of the individuals in the United States have experienced a traumatic event in their lifetime. Only 10% of these individuals develop symptoms of survivor's guilt or PTSD. There is multiple factors that are involved in developing those symptoms, and we will talk about it a little bit. The epidemiology for survivor's guilt, we know that affects 6.8% of the population, and this is a rough average. There is some evidence that goes, especially in America, goes from 3.5 to 6.8. But we also know that changes, for example, these days in Cambodia, we know multiple studies that up to 68% of the population presents symptoms that are diagnosis of PTSD, actually, that range of symptoms that are prone to have this diagnosis of PTSD. We know that the highest rate of survival guilt is among rape victims, military combat personnel, and also captivity. We also know that the rate of PTSD is way, way higher among refugees. There is a multifactorial component to develop symptoms of survivor's guilt or PTSD. We divide it in three, and first, the biological factors are the genetic vulnerability. Sometimes we have diseases that affect the brain development, and in those we noticed reduced size of hippocampal. And the hippocampus actually is the one responsible for that communication, for keep those memories actually. We also know that being a female is a contributed factor to develop PTSD. In the psychological risk factors, we have separation from parents at early age, also childhood abuse and neglect, pre-existing conditions like conduct disorders, anxiety disorders, mood disorders, and also we need to assess for alcohol and drug-related problems. I want to stop right here for 1 second, and we need to understand that many times survivor's guilt or PTSD comes actually with a range of symptoms and coping skills that include alcohol and drug-related problems. The social risk factors is that constant exposure to violence, traumas, adversities in life. Also, it's a correlation between low education and low economic status that affect or put you in higher risk actually to develop survivor's guilt. We also know that the limited social support, belonging to a higher community, a family unit, that also is a huge protective factor, or that help us to decrease the chances to develop PTSD or survivor's guilt. There is many different structures that change in our brain. Survivor's guilt actually changes the structure of the thalamus, and we also know that shrinks the prefrontal cortex and decreases the communication between the left and the right hemisphere of your brain. The thalamus is responsible for the transmission and just 1 second. The thalamus is responsible for the transmission of fearful stimuli, but also remains or holds those memories of the traumatic event and keep it actually constantly accessible to your brain. We know that the thalamus actually is enlarged and is more active in patients with PTSD. We also know the amygdala oblongata is involved in the evaluation of the threat, the response to my stimuli, and the fear condition. And we also know that the amygdala oblongata holds that stressful event and keep it accessible to your body. The hippocampus also is involved in keeping those conscious memories, many details. And we also know that the left hemispheric on the brain decreases actually after exposures of traumatic events. In the brain structure, we know that norepinephrine is increased in traumatic events. That's what gives you the symptoms of hypervigilance, those flashbacks, that is association. One of the important things is the clinical presentation, and we know that survivor's guilt affects the memory center. That alteration of the memory that in some cases we don't have the resources to deal with the memories. So the traumatic event is not processed, and that's why it's integrated in other information. So in some point, we don't know what's causing that dysregulation, if it's the memory or the constant mixing multiple information. And because of this constant alteration in your memory, that traumatic event is always re-experienced. So we always have this re-experience it constantly, and we mix reality with the past events. But we also know that it affects many other areas of your brain, like the speech center, the emotional intelligence, those memories, and also decreases my ability to verbalize. So that's why we see people that is cataphonic after an event. There are clinical presentations and key presentations that we need to identify in these patients. One of the big ones actually is that re-experiencing. Okay, here we go. So that re-experiencing of the trauma through intrusive symptoms, that visual disturbances. Sometimes people with elevated traumatic events, they perceive situations like they saw people, many times are ghosts, that visual disturbances, that difficulty falling asleep and remaining asleep, that startle effect, that inability to talk. We also know that avoidance is a huge part of survivor's guilt, that feeling that people, places, that avoidance of situations that remind us to that situation. We lost the ability to enjoy simple things in life. We call that anhedonia. And anhedonia is my inability to enjoy things that I used to enjoy in the past, like concerts, things of that nature. Also, in many cases, we also found that inability to feel emotions, that constant intimacy or sexual interest, it decreases. We also know that those arousal symptoms are constant, permanent, that irritability, anger, that hypervigilance, and as I mentioned before, that inability to talk and to organize my verbal communication in a organized manner. Concentration and sleep is very difficult to achieve after traumatic events. We needed to have a very comprehensive battery of tests for these individuals. The goal of the assessment is pretty much understanding the problem that the patient is experiencing, meeting the patient where the patient is at, okay, and having a very develop actually skills to listen to the patient, because we have to believe and we have to understand that this is a unique experience and affects each individual differently. We also need to identify the group of symptoms resulting from the trauma. We need to know if it's more behavioral issues or anger issues. We need to understand how we're going to approach this and in order to develop an appropriate plan of care. We also consider different treatment approaches. We need to be mindful of the cultural. We need to be mindful of the traditions, the beliefs, even the religion of the patient, and supported actually through his own emotions. That psychiatric evaluation is crucial, and as I mentioned before, with a series of tests that are going to allow us to have a baseline of the patient. We also need to have some data from family members because we know that the memory gets altered, so we need that support from families and people and the support system to tell us how's the daily living, how they act, what they react to, if it's noises or any trigger from communication. The treatments, there's plenty of specific treatment, but the most important goal of the treatment is to create a sense of trust, a safety, and also to separate the individual from the re-traumatization, from the constant triggers. So removing the patient from that situation or allowing the patient to feel safe in an environment that he can process his information in a different way also is highly recommended. We also need to rule out any medical issues, thyroid issues, dysregulation with the suprarenal gland, the production of cortisol. rumination on the or that rolling actually of the HPA axis when the cortisol triggers the HPA axis. Basically, the core symptoms actually is to reduce that re-experiencing, reducing also that comorbidity, and really, really important, we need to assess clear and direct for suicidal ideations. As I mentioned before, we have patients that present with anhedonia, which is my inability to enjoy situations. But then we also see many patients with dysphoria. And dysphoria is basically, what's the point of doing this? So when we have combinations of anhedonia and dysphoria, in that moment, we really need to intervene because that intervention prevents suicidality. Also, we need to allow the patient to cope with regular life stressors. Psychotherapy is being proved to be the most effective on the front line of treatment for trauma and PTSD. CBT actually in any of the modalities, CBT, DVT, any of the exposure therapy is the gold standard actually. It is allowing us to decrease that input that we have from the outer and allow us to reframe our brain. Also, EMDR is in the assumption that the dual attention between the stimuli via tapping, lights, or touching, or even finger clipping, enhance that information of safety, but also allows you to be more present, allows you to have that inventory of presence and that actual moment. So allows you to remove from those memories to the actual moment. So CBT in many of the different modalities, and these days also we are introducing a new way of regulate a set of neurons that we call the mirror neurons. Those mirror neurons, they are like alert towers. So in that realignment of that alert towers are going to allow the patient to decrease that anxiety and that constant activation. In psychopharmacological interventions, we know that the gold standard is being SSRIs, and especially Zoloft is being proved to have great results with civilians. It's a little bit less effective among combat trauma survivors. There is only sertraline Zoloft and paroxetine Paxil are the two treatments approved by FDA for the treatment of PTSD. Many of the other medications, we use it as an off-label. We know that the sertraline reduces the symptoms of anger, also improve functioning and quality of life. Paxil improves sleep disturbances, that flashbacks, that interpersonal difficulties. In the recent time, we also know that propranolol, one of the beta blockers, appears to have the ability to reduce that consolidation of the trauma emotion in your brain. So it decreases that fixation of the trauma event in your brain when the intervention is done right after the event, actually. Something that we need to know, we do not recommend to prescribe any addicted medications, any benzos pretty much, to patients with PTSD, as I mentioned before. There is a high risk for dependency and tolerance. So we don't recommend any of the benzodiazepines in PTSD patients. Also, we need to intervene with psychosocial interventions. Psychosocial interventions pretty much is that knowing that the patient is supported. Those interventions like reconnecting to people are allowing the patient to gain that agency again, to increase that sense of control, and also mastering the individual own strengths. That cognitive restructuring also helps the individual to learn that negative thinking can be the results of my unhealthy physical and behavioral problems. So those maladaptive coping skills such as substance abuse, as I mentioned before, play a huge role perpetrating these symptoms. We also have a multiple other modalities. There is a large study actually on acupuncture. We know that acupuncture, equine therapy, massage therapy. The reason that we advise and we recommend these alternative modalities, especially are because in many cases the patient is not ready to do all this hard work through EMDR or this type of therapies, exposure therapies, that we start just decreasing that reactivity from the body, and we go from the external to the internal. So we relax the body first. One of the beautiful things of working in this setting here at Sierra Tucson is that we have a multiple evidence-based modalities that are provided in the same place. We have multiple interprofessional massage therapies, we have acupuncturists, we have equine therapies. We have, as I mentioned, multiple evidence-based modalities that help the patient to regulate the body, and from that we transition the patient to work to his trauma process and get a better regulation and more emotional intelligence. So in order to apply resiliency, resiliency is a quality that we need to train actually. Resiliency is the capacity to deal with. So it's my capacity to deal with this overwhelming situation. It's my capacity to break it down and navigate through my options with more anticipating actually what can happen in the near future. We also know that resiliency is my ability to overcome the situation, and not only to overcome it, but to learn from that situation. And in many cases, even to gain from the adversity in life. Multiple of the protective factors also we need to talk about affiliation. So affiliation protects against that exposed to traumatic events. It helps to integrate the effects of experience. Thus, that affiliation to religion, to a community, to a family is a protective factor to develop these drastic syndromes. Also, the secure pattern of attachment. When we have a secure pattern of attachment, we exhibit less symptoms of PTSD and less symptoms of survivor's guilt. We know that we develop that pattern of attachment at early age, and that's why it's the importance of having that family nucleus, having clear and supported conversations. We also know that financial support is a huge factor, and in financial support, having access to resources, services, and healthcare is also important. And the last one is mastering the prior traumatic events. We know when we applied resiliency and we're doing much better in different situations, it's easier actually to overcome future events. So in conclusion, we need to listen. We need to assess the patient, and we need to take time to listen to the patient, to listen how he feels, at what time of the day is more triggering for him, or the day, nights, what works for him. As I mentioned before, we know that roughly 90% of the Americans are exposed to traumatic events, but only 10%, and as I mentioned, that severity of symptoms varies on your own resiliency and your own tools to deal with these factors. As I mentioned, lower academic achievements, prior exposure to trauma, those are, and a small hippocampus, substance abuse, conflict, and poverty are also contributors to develop PTSD. We need to rule out that comorbidity. We need to rule out thyroid issues, kidney issues, liver issues. And more important, we need to rule out that comorbidity as a drug addiction or any other mental condition. Substance abuse and suicidality is we need to ask the patient. We need to be creative in terms of, hey, how are you feeling? Were you out today? How we can support you today? Listen. Actually, I also referred to the moment of, as I mentioned a little bit ago, we always think in the victim itself, but rarely cases we go about the witnesses and we evaluate how they're doing. And also, please do not be afraid to seek help. If we start noticing that my mood is changing, that I've been isolating, that I'm being constantly anxious, those are expected for a very short period of time. If after a week you see that you're having a difficulties getting out of bed, carrying out your activities of daily living, please seek help. We have multiple resources. We have the NAMI, the Alliance for Mental Health. We also have the American Psychiatry Association. We have Psychology Today is a great resource to find out providers in your area. And of course, we need to have the suicidal prevention line very close to us. So again, I will invite you to reach out, to ask for help, to set up your support people that love you, support you, and you feel comfortable with them. Not necessarily because they're family members means that they are your support. Just establish and look around and find who supports you, who loves you. And again, listen and listen and listen.